So hello, good afternoon to all. Welcome. My name is Bevan Croft. I am a white woman with blonde hair, and I'm in my home office, which has pink walls and other brightly colored art in it. I co-direct the National Center on Advancing Person-Centered Practices and Systems at the Human Services Research Institute. And it is my pleasure to welcome you to our November webinar, Co-Producing Recovery and Resiliency in Indiana using recovery data. Next slide, please. We're very glad to be hosting this webinar in partnership with our friends at the National Association of State Mental Health Program Directors. They introduced us to Amy Brinkley and her wonderful colleagues who will be sharing their story with you today. NCAPS is a federal center, and we receive funding from the Administration for Community Living and the Centers for Medicare and Medicaid Services. We have webinars just like this every month on a range of different topics, and you are more than welcome to check them out on our website. Next slide, please. Our goal as a center is to promote systems change that makes person-centered principles not just an aspiration, but a reality in the lives of people across the lifespan. And we do that in a range of ways by providing webinars like this, publicly available resources, and also targeted technical assistance and learning collaboratives. Next slide, please. A few logistics before we get started. This is a webinar platform, so everyone is muted. You are, however, more than welcome to engage with us through the chat function. Chat is open to all. You can say hello. If you would like to just chat with the presenters, you will want to select hosts and panelists, but if you'd like to chat with everyone, just be sure to select everyone and feel free to engage and say hello. This webinar is being live captioned in English and in Spanish. To access the English captions, just hover down to the bottom of your screen and push the button that says live transcript. To access the Spanish captions, there is a link in chat that you can click, and that will open up in a separate window. We will have just one poll in a moment and also some evaluation questions at the end. So please do be prepared to interact with us as well. Next slide, please. You're more than welcome at any time to reach out to us. Our email address is ncaps@hsri.org. We will also let you know when this webinar recording, along with a PDF of the slides, a plain language summary, and any other materials are available in about 2 weeks, and those will be on our website, ncaps.acl.gov. So next slide, please. What we'd like to do next is just see who's here. I see we have folks from all across the country. We'd like you to just note here how you self-identify. This is a check all that apply poll. There are 8 total options, and if you self-identify in a different role, please enter it into chat. The roles are a person with a disability or a person who uses long-term services and supports, a family member or loved one of someone with a disability or someone who uses long-term services and supports, an advocate or self-advocate, a peer specialist or peer mentor, a social worker, counselor, or care manager, a researcher or analyst, a community or faith-based service provider, organization, or a government employee. And I will give everyone another 10 seconds or so to let us know who you are. Please take the time to do that if you're able. Oh, good. David Miller, federal advocate, and our wonderful colleague at NASHPD is here with us. Good to see you, David. Okay. So let's go ahead and close the poll and show the results, Elaine. know if folks are seeing the results. I don't see them quite yet. Can we display the results? Well, what I will say is, oh, here we go. Oh, well, I can see the results, and I'll tell you that what I'm seeing is that we have 56% of you who responded self-identify as government employees. And that's the largest, I guess, plurality, but we have a great spread across all of the other categories. People with disabilities, family members, self-advocates, peer specialists, welcome, social workers, providers, and even a couple of researchers. So fantastic to see you all. All right, we can stop sharing here. And I'm noticing on chat, we may have an issue with Spanish captioning. Please hold tight with that, and we will do our best to get that up as soon as possible. And thanks for letting us know. Okay, next slide, please. All right, so it's time for me to introduce you to our speakers. We have an illustrious panel, and at the head is Amy Brinkley, who is the Director of Recovery Support Services for the Indiana Division of Mental Health and Addiction. Amy's work focuses on quality, peer recovery, and recovery support services. And she's excited to be part of Indiana's team, advancing recovery support services and setting the bar nationally for the collection of recovery data. So after Amy presents a bit about her experiences, she's going to hand it over to a panel of folks who are going to provide some reflections based on their experiences. And those folks are Becca Sagafis, Sarah Gunther, and Tina Skeel. So Becca is the Chief Executive Officer of Essential Virtual Solutions and has more than 35 years experience in direct service, management, and operations in both private and non-for-profit business sectors surrounding mental health and managed care. Sarah Gunther is a person in recovery with mental health challenges and substance use disorder. She uses her lived experience in her role as executive director of Key Consumer Organization, a consumer-run organization in Indiana that provides empowerment and support through its peer services and mental health warm line. And Tina Skeel is the director of Indiana Works at Aspire Indiana Health, Inc. She has devoted the last 30 plus years of her life to removing barriers to employment for people with disabilities. After we hear from Becca, Sarah, and Tina, we'll hear from a couple of folks who will provide a little more of an overview of the data portion of this initiative. And that'll be Ari Nasiri, who's the Director of Behavioral Health Integration for the Indiana Division of Mental Health and Addiction, and his responsibilities focus on progressing the level of data integration across behavioral health. And we'll also hear from Wendy Harold, who's the Executive Director of Data Strategy for the Indiana DMHA, Division of Mental Health and Addiction. She oversees certification and licensure, quality improvement, data and performance measurement. And to kick us off, we will hear a bit from Jay Chaudhary, who is the director of the Indiana Division of Mental Health and Addiction. Jay, welcome.
Hi, good afternoon. Thank you for having me. I'm super excited to be here. Jay Chaudhary. I'm male. I'm of Indian origin. I have glasses, and I'm speaking in front of a background that says "Be Well, Indiana" on it. I'm in my late 30s. I have a very round face, so hopefully that will paint the picture. So I'm thrilled to be here today to just kick off and highlight the work of the folks on the panel. I am, as always, just in complete awe that I get to work with and in some cases supervise the folks on this panel who are doing amazing things in the state of Indiana. And I just was tasked with kind of setting the stage and giving you all the backdrop and the kind of core principles that direct our work in the state of Indiana. And so if we can go to the next slide. Great. And we'll go and go one more. So this is we're part of the Indiana Family and Social Services Administration, which is the Health and Human Services arm of the state of Indiana. And one more slide. Thank you. So at DMHA, our vision is an unyielding focus on promoting and supporting the mental health and wellness of the people of Indiana, and we adopted this vision about a year ago. The key there for us is unyielding. There's a lot of noise in this job and in this role at the state, and so our goal and our aim and our North Star is to cut through it and do what's best for the for the folks that we serve. And that's not always the case. It's somewhat aspirational, but that's our goal. And our mission is to champion mental health promotion and substance use disorder prevention, treatment, and recovery systems that are high quality, seamlessly integrated, and accessible to the people and communities of Indiana. The inclusion of recovery in our mission was very intentional and really has been, I think, both driven by and a driving force of the work that you're going to hear about in this webinar today. Next slide. So I just wanted to highlight a few kind of key concepts that to me drive my approach to this work, and I hopefully has filtered down somewhat to DMHA as a whole and our recovery work in particular. So one of the things we've done is I try to take a page from the recovery community, as many of you are familiar with the Serenity Prayer, and so. A lot of times in the role of overseeing an entire state and overseeing, a system that serves hundreds of thousands of Hoosiers every single day, it can be overwhelming, and you can really focus on, you can really get frustrated and overwhelmed by all the different things that you have. And so one of the things that we've really tried to do, and hopefully with some degree of success, is take what we call the Serenity approach to this, which is focus on what we can control. And so that doesn't always, again, it's aspirational, doesn't always work. And then in particular with recovery, we're always mindful. And I saw this phrase, just a few months ago, and I thought this was just perfect. And I think it's something that we always have to remember. And I think a lot of times in the role of the state mental health or addiction authority or whoever or government, or we get really fixated on the use of the substance, right? And we forget about the reasons. And I think that regardless of what those reasons are, it's a very person-centered, personal thing. I think we always have to remember that people use drugs for reasons, and it's not about the substance or the use or the illegality or whatever about it. It's, I think that those reasons are really important, whether those reasons are trauma or, untreated mental illness or, just difficulties in life. And I think that, we need to remember that in our particular position. The third thing is this idea that recovery is easier when life is, right. And so our job, and part of our job, we see very much part of our job is not only making access to treatment easier, but helping folks make their life easier, whether that's through access to the childcare, or transportation, or housing, or peer supports, or other sorts of things. Because we know that recovery is the part of this journey that takes place in your life, and recovery is easier when life is. And then finally, we truly believe in the power of lived experience, 100% to our core. And so, one of the phrases that's been thrown about, and kind of what we want to get to is, there's a peer for that. No matter who you are, what you're going through. We believe in the power of connection through lived experience to get you, to where you hope to be. So those are the concepts underpinning our work, and you will hear much more about that work in detail from our amazing staff. So thank you for having me, and I appreciate the opportunity.
Thank you, Jay. Good afternoon, everybody. My name is Amy Brinkley, and I am a 41-year-old white/Native American female with brown curly hair that pulled up in a ponytail today, and I'm sitting in front of a bookcase. So if we could go to the next slide. So my title is Director of Recovery Support Services, and I have been with the Indiana Division of Mental Health and Addiction for 4.5 years. In this current role, I was just recently promoted, so that's rather new. In my time at DMHA, one of the first things that stood out to me was the silos. We had a number of advisory councils that Jay used that term underpinned, and so now I'm leaning into that. But we had a number of advisory councils that would advise the division on various topics related to recovery support service needs that weren't necessarily working together always. So systematically over the last 2 years, we have begun to intentionally de-silo those efforts by intentional collaboration. Next slide. So the two main advisory councils that we're going to talk about today are the Indiana Recovery Council and the Recovery Support Work Group. So the Indiana Recovery Council is our consumer advisory board that consists of 16 people with direct lived experience in mental health and substance use disorders. The council acts in an advisory capacity to DMHA and is essentially our voice for people across the state with mental health and substance use disorders. Next slide. So the next advisory council we're going to talk about is the Recovery Support Work Group. So the Recovery Support Work Group is comprised of more than a dozen state agencies, community statewide stakeholders, and more than 51% of people with lived experience. So the Recovery Support Work Group uses recovery data to validate the lived experience feedback from the Indiana Recovery Council and helps to inform DMHA by making recommendations for funding policy and programs related to recovery support services. Next slide. So we've tried to summarize the work holistically into 3 steps. So step 1, the Indiana Recovery Council, our consumer advisory board, identifies lived experience gaps and needs across the state for mental health and substance use disorder related needs. Step 2, the Recovery Support Work Group provides data informed recommendations to the division to address the lived experience gaps identified by the Indiana Recovery Council. So step 3, DMHA, the Division of Mental Health and Addiction, us, would then review and accept or reject those recommendations based off of the available data. Next slide. So in 2012, the Recovery Support Work Group conducted a statewide gap analysis that identified the top 5 supports missing as being personal support networks, peer support services, hobbies and interests, prevention and wellness, and safe and affordable housing. The state agencies in our Recovery Support Work Group also identified that employment is intrinsically essential throughout each of these priorities. So we have an employment subgroup as well to focus in on those needs. In 2020, we contracted with Essential Virtual Solutions and began to just do a review of our membership across the Recovery Support Work Group because we want to make sure that we maintain that 50% of people with lived experience being represented. We also began to standardize our process for goals and objectives and identify outcomes that each of the subgroups wanted to work on throughout the next year to 2 years. We began to create templates for our data reports. We wanted to measure outcomes, and we added a data group to kind of help us coordinate these efforts across each of the subgroups. So the gaps identified on the left of the screen, personal support networks, peer support services, hobbies and interests, prevention and wellness, safe and affordable housing, employment, those are all individual subgroups made up of state agencies and people with direct lived experience, focusing in on those areas. In addition to that, we began to standardize our forms. So we created charters for each of the subgroups. We created data set briefs for each of our data sets. And then we created a data request form for the subgroups to request data. And our vendor created a process flow chart. So Becca, I know that you're here, so I'm going to go ahead and put you on the spot just for a moment. Is there anything you would like to share on this specific process?
Absolutely. Thank you, Amy. Hi, this is Becca. I am a 60-year-old white female with brown hair that has natural gray highlights and hazel eyes. I am in my home office with the bookcase behind me. I have on an ivory sweater and I'm wearing glasses. I really was honored when Amy approached me about the opportunity to work with them and the members of this recovery support work group. The original members really of the work group were the subject matter experts on key areas and were very willing to be direct and honest on what they perceived as barriers really moving the process forward, as well as what they would like to see the RSW achieve in the future. It was clear that some members were feeling somewhat stuck and maybe a bit frustrated at that time. So we really took a step back, reviewed, considered, and respected the previous efforts and work while creating and developing a customized process that builds upon the original foundation. In essence, we spent considerable time and efforts conducting gap analysis back in 2012 that they did that identified significant gaps, issues in access to personal support networks, the peer support services, the hobbies and interests, the prevention and wellness, the safe, affordable housing. And along with those areas, as Amy shared, employment supports were noted as being a thread throughout each area and was formally included in our development process. For me, really getting to know the DMHA team and the RSW members was the most important first step that allowed us to create and develop a more formal process to ensure that their expertise and opinions were not only heard, but truly considered and acted upon. Once we identified our overall mission, we were off and running. Thanks, Amy.
This is Amy again. So next slide, please. So there's no doubt that without Becca's support as our vendor, our contractor, our quality improvement specialist, we would not be where we're at. And so we've been very lucky to have her. So we're also going to take a moment here to call on the panelists. So we're going to go in order. We have Tina Skeel, Sarah Gunther, and then Becca Sagafis. So we've asked them to just share their role and perspective throughout the process. Some of our panelists have been part of the recovery support work group before we made these changes in the last 2 years, and some are kind of new. So I think that their perspectives are very valuable. So first up, we have Tina.
Hi, thank you so very much. I am very honored to have the opportunity to come and share my experience with the recovery support work group. It's been a process, and I think we've already heard some of the kind of waxing and weighing of how this actually went about. I want to first start out by saying my name is Tina Skeel. I'm the director of a Social Security Work Incentive Planning and Assistance project that is housed through Aspire Indiana Health. I also am very active in our Indiana APSE chapter as far as public policy, and a lot of the conversations around recovery supports are near and dear to my heart. I'm a shorter statured, dark blonde, or at least that's the color I'm going to call it right now, dark blonde hair, white female. And I am coming to you from my home office. I'm wearing a blue dress with a white cardigan, and hopefully you may get to enjoy some of the art behind me as well. So let's talk a little bit about my role. I'm going to kind of take the first question and just kind of blend them all together. My role with the RSW was very focused on residential and vocational services because employment programming had been my background for many, many years. And we know that is such an essential part of recovery services. I was one of the first members of the RSW in 2012. So I really got to watch things as we kind of developed through various levels. One of the things that the director of the Division of Mental Health did was really allow us to have ownership of this group In the very beginning, that first gap analysis in the initial work that we did, most of us were volunteers with just a few staff from the Division of Mental Health. And so we were charged with a lot of responsibility as a work group to data mine, to analyze, and then we did write-ups and created products for the general public. We even presented throughout the state of Indiana on our efforts. So many kudos, because I think that really allowed us to really buy into this process. And I think it's really one of the reasons why we stayed together. It's been exciting and sometimes scary to see how things have changed. As Amy mentioned, there was a time where there was about a year or so where we weren't sure exactly where we were heading. And I just want to thank Jay and Amy for taking the bull by the horns and allowing us to move forward. Because if you have a good foundation, keep building. So, all right, I'm going to pass it back over to Sarah. If you want to turn on your camera.
Hello, my name is Sarah Gunther. I'm the Executive Director of Key Consumer Organization. I am a 40-year-old white woman with short dark hair and glasses, and I'm wearing a gray sweater. I am on the Hobbies and Interests subgroup, as well as on the Peer Support subgroup for the RSW. And I did indeed feel part of the decision-making process, moving from a more informal to a more formal way of doing with the RSW. And it was very nice. I started in 2019. So I started right at the beginning of this more structured program. And it was great to see it come together. It was great to see everyone work together to try to become more meaningful and more data-driven in our recommendations. And I believe, Becca, did you have anything else to say?
Hi, yes, this is Becca. And my role on the RSW is to assist at facilitating the overall change process. When I started approximately a year and a half ago, we continue to work on tweaking areas as we encounter, issues along the way, and continue to do this in the future. Really, at this time, I feel like I am now taking a more supportive role in the process. It's been a wonderful experience for me to work with so many amazing and dedicated people. Amy has been a very strong leader, advocate, networker, and a chairperson for the RSW. And we have some very strong chairpersons and members of our subgroups. And as you heard from actually Tina, I've known Tina for a while here today. She's been involved really since its inception. So they're just exceptional people, and I'm very proud and honored to work with them. Thank you.
This is Amy again. Thank you, Becca, Tina, and Sarah. We're going to hear from them again here shortly. Can we go to the next slide, please? So one of the things that we did with our survey back in 2020 is we asked our members to help us identify a mission statement. And so the mission statement that was born out of that survey is this: our mission is to recommend and promote identified needed supports and resources for individuals in wellness and recovery from mental health and substance use disorders. I'm not going to read the entire list on the right side of your screen, but I will say that our stakeholders consist of 26 or 27 statewide stakeholders and state agencies, and are represented by more than 50% of people with direct lived experience. So we've definitely grown significantly in the last 2 years, but I think it's been a very positive change. Next slide, please. So a couple of the data sets that we're going to talk through today are on your screen. So the first one that we're going to dive into is the lived experience feedback survey. The second one is the consumer satisfaction surveys. The third one is our assessment data, CANS and ANSA. The fourth one is our social determinants of health data. The fifth one is our recovery data platform. And one of the things I like to mention on this slide is that we also have a data software system that we call the Management Performance Hub, which was actually born out of a governor's executive order that created a warehouse of cross-state agency data collection. So we have not begun to fully use that to our advantage for this specific purpose yet, but we do know that that's available, and if we want to move into using that more, we will in the near future. Next slide. So the first data set we're going to talk about is the lived experience survey. This was a survey that was completed by the Indiana Recovery Council. So it's a consumer-driven survey. The idea being that we bucketed gaps and needs into themes based off of SAMHSA's dimensions of recovery. So within each of the questions that were asked, there were 19 total. We always left one open-ended response for people to add in their own words, in their own voice, an answer to a question. So we wanted to very much keep this qualitative and quantitative in nature. At the end of the survey, what we did is we took all of the open-ended responses and we color-coded them by dimension. So for example, our state agencies that work in housing could go to the bottom and look at the color code that matches home and identify exactly what consumers are saying about housing across the state. The next thing that we're going to be doing is hosting statewide listening sessions. So we're hoping to do that this next state fiscal year to further fill in needs as identified in the survey. One of the other benefits of the survey is that we were able to identify recovery and wellness needs by demographics. So no different than prevention or treatment, we know that recovery support service needs are different by demographic. So age, race, location, length of time in recovery and wellness, those things matter. And we'll tell the story on what the needs are. Next slide. So this was a first-time survey last year. There were 19 total recovery-centered and demographic questions. The survey was open for approximately 4 weeks. The survey was sent out 6 months into the pandemic. We had 199 people across the state respond with mental health and substance use lived experience. That breakdown resulted in 20% of the respondents had mental health lived experience. 50% of the respondents had co-occurring lived experience, 18% had substance use disorder only lived experience, and about 11% of the respondents were family members. Next slide. There we go. So one of the very first questions on the survey, I'm not going to share the comprehensive survey with you guys because we have a number of other data that we want to look at. But here's a couple things. So the very first question on the survey was based off of SAMHSA's dimensions of recovery. What is missing in your daily recovery or wellness journey? And so on the front end, it would appear that purpose was identified as being the primary missing dimension across the state for people with lived experience. But when we started to filter it out by demographics, we began to see some very clear disparities. For example, people, Black and African American folks identified housing or home as a missing component to their recovery journey, almost double to those white and Caucasians respondents. So the disparities began to become very clear. Another one was barriers to treatment and recovery support services. So the other one we noted too was transportation. So Black and African Americans identified transportation as a barrier at 50% compared to white and Caucasians at 31%. So by adding those demographic questions, we were able to start digging into the weeds on what the recovery support service needs were by demographics and to see the disparities. Next slide. So next we're going to talk about our consumer satisfaction surveys. So Ari Nasiri, one of our colleagues, is going to share here. Go ahead, Ari.
Yeah, thanks, Amy. My name is Ari Nasiri, and although I'm pretty washed out by the light, I'm a Middle Eastern man, black hair, and I'm wearing a blue shirt that looks pretty white and in front of a forest background. I'm the Director of Behavioral Health Integration here at DMHA. Now, the consumer satisfaction surveys that we send out are sent out to our certified community mental health centers here in Indiana. They're sent out to all of them. And they're the Mental Health Statistics Improvement, the MISIP, and the Youth Services Survey for Families, the YSIF. They're standardized surveys that get about 8,000 responses annually, and these are given to consumers at the CMHCs. And the CMHCs themselves do distribute and collect these surveys. They're open-ended questions that we then take and look at and see for our purposes what buckets they fall into and which subgroups can utilize the questions best to answer some of their questions. But since they are distributed and collected through the CMHCs, we are aware that they tend to skew pretty positive. And so that is one thing that we take a look at as well. And I'm going to go to the next slide and hand it off to Wendy Harold. Wendy.
Hi, I'm Wendy. I'm a white woman with long brown hair and glasses. I'm going to talk to you about the assessment data that we collect. We have two assessments, the CANS and the ANZA, that the CAN stands for Child and Adolescent Needs and Strengths, and ANZA stands for Adult Needs and Strengths Assessments. We chose these assessments in 2007 and 2008 because they were holistic assessment tools and they had a focus on strengths. So not just looking at a client's needs, but focusing on what can be used with the client's strengths. The data from these assessments can inform treatment planning. They can monitor progress, evaluate services, and they're used in decision support. They have a simple 0 to 3 rating scale, which I'll show you in a second. The main categories are life functioning, behavioral health needs, risk behaviors, and strengths. Provider staff complete a CANS or ANZA, whoever is age appropriate, with individuals at admission, every 6 months, and at discharge. These are copyrighted tools, and so I've given you the link if you're interested in finding out more. Next slide, please. So as I mentioned, it's a 0 to 3 rating system. 0 would mean that there's no need in the particular item. 1 would mean that it was a historical need, or there may be something there, but it's not anything that we need to act upon. And then 2s or 3s are actionable needs. So when I talk about items later on, I'm talking about these two levels. The actionable needs, either I need to deal with it immediately, 3, there's something dangerous about it or very urgent, or 2, I need to have it in the treatment plan. It's something that we need to address. Next slide, please. So strengths are a very similar rating system. So 0 and 1, we don't have to do anything with these. These are strengths that are present, and we can put them in, work with the clients in putting them in their treatment plans and utilizing them. 2s and 3s are strengths that they don't yet have, but we can build them. And so later on in slides, I'll be talking about building strengths. Next slide. So in this project, we took the ANZA items and selected and grouped them according to the SAMHSA's dimensions on recovery. So these aren't all the ANZA items, but these are the ones that we felt fit into these categories. So in health, we have medical, physical, involvement in recovery, self-care, sleep, and medication involvement. For home, we have independent living skills, community violence, residential stability. In community, we have community connections, family functioning, social connectedness, transportation, traditions and rituals, social functioning, family strengths, natural supports, cultural identity. And for purpose, we have employment, volunteering, optimism, resourcefulness, job history, educational, talents and interests, spiritual, and religious, recreational, and resiliency. Next slide, please. So this is an example of one of the reports that we created for this project. So we created a report for each of the dimensions so you could see all of the items. The blue bar represents time 1 and how many people had that as an actionable need or a buildable strength. And time 2 represents the person's assessment in state fiscal year 2021. This data is specifically for those that have substance use disorder in our system. And the percentage, if it's positive, it means it's trending the right way. So the first 2, you'll notice it's going down. Those are 2 needs. So you want to have needs be reduced over time. And then the ones that go above and they're positive, it means that they're strengths and you would want to see the strengths built. So the 2 things that the subgroups can discover from this is, one, at the initial assessment, what are the highest needs or strengths that need to be built, so we can come up with strategies and ways to address that. And then all of these are trending in the right direction for purpose. That's not the case for all of the dimensions. So they can look at the things that are trending in the wrong direction. So over time, people are actually getting worse, or more people are identified with a particular need. So they could help to address that. Next slide. So just that overview is not enough. So there's a couple different strategies we also have to look a little bit deeper at the data. So the first thing is we can look at an individual item and see what's happening with that over time. So I'll show an example of that report in a second. We can also look at actionable needs for an item by county. So we have a report that we can run that shows how many actionable needs for a particular item, and we can rank them to see which counties have a more significant issue with this particular item. And then we're also looking at strategies to link this data with other data like chronic health conditions and Medicaid data to get a better idea on what's happening with the consumers. Next slide. So this is an example of looking deeper at one specific item. So this is the employment item. The first blue bar shows at initial 41% of clients with substance use disorder rated had an actionable need of employment. Then the next bar shows that continuing means that of those, 60% continue to have that need on that second assessment. Clinical progress means 47% of those 41% went from a 3 to a 2. Newly identified means that there wasn't an actionable need there. On the second time, there was. They identified employment as an issue. And then worsening is going from a 2 to a 3. So by looking at this data, we can see a little bit more about what's going on with this specific item. Then we can look at those. We can look at the actual people, look at their demographics, look what counties, providers are serving them. There's a lot of different ways that we can look at this data. Next slide. So we wanted to give you an idea of looking at all of those recovery items that I read out. If you sort them by most common, either actionable need or buildable strength, this is what came to the top. So for those with serious mental illness, sleep, social functioning, resourcefulness, family functioning, and recreational were the top items. I'll mention that the list for those with serious mental illness and those with substance use disorder is different, and I'll show you that in just a second. But I mentioned that because resourcefulness was an issue, buildable strength that was needed both for serious mental illness and substance use disorder. Next slide. So resourcefulness, as I mentioned, it's the top one for substance use disorder clients. Optimism, legal, family strengths, and resiliency. So this just gives you a kind of an idea of what we can do with it. The next slide, and thank you so much. Oh, I'm sorry, this slide's mine. So the next things that we're going to do is we're meeting with each of the subgroups and sharing this data and deciding what additional analysis they want. And then we're also looking at research of what recovery supports have had positive results. Thank you. Next slide.
Thanks, Wendy. This is Ari again. Now, what we did next, as we were getting together and talking during the RSW meetings, in 2018, we heard that FSSA, our mother agency, the Family and Social Services Administration here in Indianapolis, had been working on creating a social determinants of health survey, and actually done so, and that this survey was pulled from FSSA's own data, and they created themselves. And what they did is they asked everyone that was applying for any kind of public assistance through FSSA online to fill out a 10-question survey. And it was presented to every Hoosier, and it was stated that explicitly that participation in the survey did not impact eligibility for services in any way, shape, or form. And these 10 questions were then crosswalked for our purposes. We took a look at these questions and we crosswalked them with ICD codes to connect them with folks that had previously been engaged with Medicaid and had identified diagnosis of either SMI or SUD or both or neither. And then we also took a look at how those matched up with social determinants of health. So if we could go forward. Next slide, please. So the original FSSA social determinants of health questions, there was 10 of them. And those questions were: first, not enough money for food in the last 12 months. Second, utilities shut off in the last 12 months. Third, fear of not having stable housing in the next 2 months. 4, problems getting childcare. 5, cost preventing seeing a doctor in the last 12 months. 6, transportation preventing seeing a doctor in the last 12 months. 7, need of help reading or understanding hospital materials. 8, fear of being hurt in the home. 9, actively seeking work in the last 4 weeks. Or 10, not engaging in regular exercise. And for our purposes, what we did is we took a look at surveys and other information that we had, and realized that of these questions, 2, utilities being shut off in the last 12 months, 3, fear of not having stable housing, 5 and 6, which were cost and transportation respectively, preventing seeing a doctor in the last 12 months, 8, fear of being hurt in the home, 9, actively seeking work in the last 4 weeks, and 10, not engaging in regular exercise, lined up with a lot of what we were seeing from surveys of our consumers. Next slide, please. So this is a still picture of what we ended up creating. And what you'll see here, and doesn't exactly show it because it's a still picture, and this is a Tableau dashboard. So what this actually allows us to do, and what you'll see on the dashboard, is there are several different segments. One is a map of the state of Indiana split up by counties. And currently it has all them colored the same way. But when you drag your pointer, your computer pointer over these counties, it'll let you know what the numbers of those assessments were for those responses. And then on top of it, it'll simultaneously change. So if you were to click a specific county, such as Benton County, all of the other pieces of the dashboard would filter only for Benton County. And the other pieces of the dashboard are the number of assessments that were completed, the percent of respondents, the values of how many folks responded to the 10 questions, and then demographic breakdowns of the folks that responded to the survey. I'm going to wait for a second. And those demographics are age, education, ethnicity, gender, and marital status. And this is the FSSA agency one. So next slide, please. What we ended up doing is creating the mix. And so we took all of that SCOH data that had been accumulated and matched it against folks that had SMI, SUD, both co-occurring or neither. And then we created our own dashboard from that mix. And then we provided it to our subgroups so that they could take a look at how the social determinants of health are affected across Indiana in different counties, as well as by a couple different demographics, which were gender, race, and age group. And it allows us to filter out for those specific groups, whether they have either diagnosis as well as the years which they responded. And next slide, please.
Thank you, Ari. This is Amy again. So in case you aren't noticing, there is a theme. Essentially, what the Recovery Support Work Group has done is we have taken existing data and just begun to categorize it within SAMHSA's dimensions of recovery. And the last data set that we're going to talk about today is the Recovery Data Platform. So we have contracted with Faces and Voices of Recovery, a national organization that goes by favor. And we have contracted with them to get the Recovery Data Platform. We are providing this resource to all of our peers within our regional recovery hubs or our recovery community organizations. So currently we have 21 plus and growing recovery community organizations across the state, providing mental health and substance use disorder peer support. And the Recovery Data Platform provides a way to capture what favor calls recovery vital signs. So when we go to see a primary care physician or a general practitioner, typically what happens is you would have your vital signs checked. So the idea here is that if you are going to see a peer or a recovery coach, that you would have your recovery vital signs checked on a regular basis. And what that involves is 3 different scales that are self-reported. It's the Brief Addiction Recovery Capital Scale 10, which is 10 questions, the Engagement Scale, which is 10 questions, and the Lifestyle Scale, which is also 10 questions. And our peers are the ones administering these scales and monitoring the recovery vital signs. The RDP, or Recovery Data Platform, launched in 2020. And to date, our recovery vital signs are still not captured consistently. So we do have some room to grow in this area. Next slide. So this is a cloud-based platform for our recovery community organizations to use. It allows our peer-run organizations to capture things such as general interactions, intakes, referrals. It includes a way for our peers to do RAP, or recovery management plans, create SMART goals and action plans. The recovery vital signs, like I said in the last slide, are three different scales. The idea being that the Brief Addiction Recovery Capital Scale would be done once a month or bi-monthly to monitor recovery capital. And the Engagement Scale would be completed once a week. The Engagement Scale is 3 scales in one. So it's the Outcome Rating Scale, the Relationship Rating Scale, and the Cravings Rating Scale. And then we have the Lifestyle Scale. We initially piloted this recovery data platform with our mental health organizations as well to see how well it would work in a mental health setting. And it works, probably not as seamlessly as the addiction recovery community organizations, but there is flexibility to use mental health peer supports and create your own scales and outcome ratings within the RDP. Next slide. So this is just a breakdown of the questions. So the recovery vital signs, the lifestyle scale is one that we've encouraged our recovery community organizations to capture. One of the benefits of the lifestyle scale is it's capturing general social determinants of health related data. But what we really wanted to know was whether folks coming to recovery community organizations had insurance, And so if they do, then the idea being that the peer would connect them with the appropriate treatment and resources, because our recovery community organizations are primarily supported by block grant. The next one is the BART 10, which is 10 questions that are, I would say, a shorter version of the addiction recovery capital scale. So it's one question from each of the 10 domains within the addiction recovery capital scale. So it's just a way to measure recovery capital ongoing. And the peers are the ones administering the scales, and these are self-reported in nature. So the recovery themselves would be the ones entering the responses. Next slide. So the engagement scale is a sliding scale, and it's the 3 scales in one. This is the outcome rating scale, the cravings rating scale, and the relationships rating scale. The idea here being that with the outcome rating scale, it's just a general check-in. Our folks, so for example, thinking back over the last 7 days, how have things been going in your relationships? Are you connected to other people? Are you staying plugged in? The next question, how have things been going for you socially? So how connected do you feel? Are you doing things? And then rate how things are in your life overall. So just general check-ins. The cravings rating scale is self-explanatory. So what has your craving level been during the last 7 days? How do you rate your cravings in the last 24 hours? The relationship rating scale is primarily going to be used during supervision. So it's a way to capture how folks are engaging with their peer and whether they're feeling connected to the person providing direct peer support. So if I'm a supervisor, if I'm a peer supervisor, and I notice that one of my peers have 10 people who are not rating them well as far as connecting, then maybe that's a supervision issue that I need to have a conversation with my peer about, versus if I notice that the peer has 1 person out of 10 who are not connecting well, maybe that recovery just isn't connecting to this specific peer and might do better with another person. So it's a way to really monitor the engagement between the recovery and the peers. Next slide. One of the biggest, this is an example of the scales that are presented through the report. So when we pull reports, we can pull this on the individual basis, we can pull this on the agency-wide basis, or we could look at the state. So one of the biggest selling points for us was the preventative analytic component. So the idea being that just with the engagement scale, if we're capturing this data over time, it tells a story. So if the outcome rating scale is extremely low, well, let me back up. So let me give you an example. So if I'm working with somebody who's had 3 relapses in the past 12 months, and I'm capturing their recovery vital signs as I'm supposed to be, then I will have a record of what their vital signs were prior to a relapse. The idea being that hopefully I can get in front of number 4. So if they're not feeling connected, if their outcome rating scale goes down and their cravings rating scale rises, we should be monitoring that and tracking that. So there's a preventative analytic component to this, which was a huge selling point for us. Because our recovery community organizations are not quite capturing the information consistently yet, we've not been able to use that to its full capacity. So we'll get there. Next slide. So to date, as of July 29th of 2021, we had 21, actually today we have 21 organizations using the recovery data platform. We've issued more than 100 licenses to peers across the state. We've captured 1,200 recovery vital signs. We had 2,200 individual participants entered into the recovery data platform, with 1,800 of them engaged in July of this year. In June of this year, just 1 month, 2,072 people were served through direct peer support. 1,557 people were served through group peer support. And then to date, this is from April of last year, to date, as of July, we had served 17,920 people through direct peer support and 16,340 people through group support. with about 5,600 referrals being made through our recovery community organizations. And 2 years ago, none of this would have been possible because we had one recovery community center that we were funding. And to date, we have 21. So this is a way for our newly formed recovery community organizations to capture data effectively. Next slide. So everything that we've talked about are the different data sets that we have identified could be used for recovery support analysis. And so the idea being that we take this data and we present it to our recovery support work group members, and they make recommendations for block grant spending, policy programming to the Division of Mental Health and Addiction. So that's all the data that we're going to talk about right now, but let's take a break and pull back Tina, Sarah, and Becca. You guys don't have to reintroduce yourselves per se, but maybe just go in that same order and just take a couple minutes here and share your reflections on this process as we've tried to coordinate this data. Just share kind of your experience from your perspective as we've evolved. Tina?
Thank you. I just have to say, the way I feel about this is we have come a long way, a really long way from the days where we were laying all kinds of data surveys out on the table and trying to correlate them. And it's not been the smoothest ride. We've had kind of some ups and downs. One of the biggest challenges we really had to do with staff turnover, particularly in the division and with those stakeholders that were on the subgroup, because as you bring in someone new into the group, things change. That form, norm, and preform all kind of change. So we had kind of a rocky road once we lost our first champion of this process. But I want to leave you with three main points. And the first point is about getting a champion. This was an enormous project. I feel that we're finally at the preforming stage, but it was a lot of work in having those champions. I mentioned Amy, but when you look at organizational change, it really comes from the top leadership. And if we had not had good direction and support from Jay and his team, I'm not sure that we would have made it this far. So finding that champion and making sure that it's supported all the way through the organization itself. The second thing that I think was kind of a learning moment for us was that you really don't need to reinvent the wheel. We created all these different surveys, and you heard Ari talk about, hey, social determinants of health through the state already had data points. All these different agencies had data points. It's just going out there and finding them. So know that if you have a good foundation, that you can build something really, really great. And you don't need to go out and spend a lot of time creating fancy surveys. My guess is in your state, there's probably a wealth of data. Most states have data warehouses. And if you can get access to that, that can make life a lot easier. The second thing really is to make sure that, or the third thing is to make sure that the voices of those that you're serving are at the table. We found it vital to have those folks adding their comments along the process. There's an adage that I've heard many, many times, and I think it really stands true, which is nothing about us without us. And so I just want to share that with you all. Sarah, you ready to go?
Yes, this is Sarah, and I just wanted to also just reiterate what Tina had said about having people with lived experience at the table and having a prominent seat at the table, because it's so important. You don't want to get lost in so much data that you forget that we're dealing with people, we're dealing with people's lives, and it's so important that we are providing support to them so that they can live their lives in a self-directed and in whatever way, is best for them that they determine. So I think it's very important, as Tina said, that people with lived experience, both substance use and mental health lived experience, are at the table and have a prominent voice. Becca, did you have anything?
Hi, Sarah. Thank you, and Tina. Thanks a lot. I'm just going to echo what both Sarah and Tina said. Also, just adding a couple of things. Really accessing the data to identify the gaps and issues has been an area of focus for the recovery support work group. The data that Amy, Wendy, and Ari had shared, they really has been recently completed and or initiating. And we're working toward that ability to have the data accessible for the subgroup review as needed. So that's really kind of continues to be in process. We've also been identifying available data sources and completing a data resource catalog, and that's been helpful for the process as well. As Tina shared, it's just where is the data? So really we're kind of trying to find that and to find really good, reliable information and data. Also, just frankly on my end, is having a team of individuals at the state and the community who are just passionate about what they believe, dedicated, and have that expertise needed to see this succeed has been extremely important to the success of our process to date. And again, true and actual collaboration between individuals with lived experience, the state and community agencies is a must. I'm just going to suggest you start there. It must be real. Not just having someone sit in on a meeting or on a board or a committee to say that they are participating. It has to be an equitable partnership of collaboration. And this takes real time and effort, but I think in the end, it really pays off for success. And again, it's been an evolving, amazing process, and I have been just honored to be a part of it. Thank you.
Thank you, Becca. This is Amy again. So one of the things I want to say before we move on to the next slide is that some of the unique things that we're seeing unfolding within the work groups is the de-siloing of state agencies. And so we have people with direct lived experience within each of the subgroups talking about real life situations and needs that can be easily addressed, whether through funding or a policy change. And by having the work groups, coming together and the state agencies being there and people with direct lived experience, there's also people at the table who can just with a snap of a finger make that change. If it's just a policy change, we've seen things happen where they just say, okay, let's fix that. And it's a done situation. By just creating that safe space to have conversations, to have targeted effort and focus in these areas has really been amazing to watch. Conversations unfold, relationships happening. We've had some new funding. For example, our peer subgroup identified housing as a large need for people with mental health concerns. And so we had the housing group on the calls, and we were able to create a new funding stream to train peers on how to become housing navigators to address the needs. So we recognize that housing system is extremely comprehensive and folks don't really know where to go or how to access the type of housing supports that they need. So let's train peers with direct lived experience to address that need and become housing navigators. So it's just been really an awesome experience to watch state agencies' participation and collaboration relationships unfolding. So next slide. So next steps for us, we are going to continue to standardize and visualize our recovery data collection. We are working on creating some recovery dashboards and continuing to do some resource mapping. We are also working on funding some research efforts to capture the return on investment for individuals and communities when the dimensions recovery elements are available. So when we make resources available to meet the need, what are the outcomes when we focus in on doing that? So let's focus in on the ROI. We also want to continue to solidify the lived experience feedback loop and amplify consumer voice and choice to drive division of mental health and addiction decisions, programming, and funding initiatives. For too long, we've gone from the top down. And in this process, we're really starting from the bottom up and identifying what the needs are, looking at existing data sets and categorizing it by recovery dimensions, and then making recommendations with the right people at the table who can make the change that's needed. And that's really where we're at. Some really innovative things we've seen come out of this is the lived experience survey that was completed by the Indiana Recovery Council last year was used in the addiction treatment strategic planning. So they looked at the feedback and said, okay, based off of what folks are saying with substance use disorders, which direction do we need to go? Where do we need to focus our efforts? The Indiana Recovery Council lived experience survey also made space for folks to continue to get engaged or stay engaged. And so we were able to create new focus groups based off of people who responded to that survey. And we accessed FSSA, so Family Social Services Administration, and DMHA were able to access people who we previously did not have access to be part of our focus groups. So we're not tapping the same 5 people to get the feedback that we need for the state. We're branching out, and we're hoping that the listening sessions will continue to help us get new voices to the table. And that's where we're at. I just want to take a moment and say thank you to David Miller with Nashville for introducing us to Bevan and for this great opportunity to present to you guys on the work that we're doing. We're happy to answer any questions, and we just want to say thank you guys for attending and hope everybody had a great holiday.
Hey, this is Bevan. Thank you so much, Amy and team, for all of this information. It is really exciting to see the ways that people with experience and system folks are partnering, and systems folks with lived experience are all partnering together to use data. We've had some really excellent questions come through in the Q&A pod and in chat. So I think we'll have plenty to take us to the end of the hour. A few questions, and maybe I'll just start with some quick ones. One is the IRC, the Indiana Recovery Council, and the RSW? Now I don't have the acronym top of mind. Maybe you can tell me. But anyway, are either of those two, the IRC or the RSW, accepting new members currently?
Yes, both. This is Amy. So yes, both are accepting new members. So the Indiana Recovery Council is striving for equal participation from both mental health and substance use disorder people with lived experience. And so we're really trying to identify more people with mental health lived experience right now. So we are accepting applications for sure. Now for the recovery.
Oh, no, go ahead, Amy. My follow-up question will be, how can people get in touch with you if they are in Indiana and are interested in taking part?
Okay, I can add a link, a quick Google search to DMHA Indiana Recovery Council, which should bring it right to the top. So the other thing with the Recovery Support Work Group, our chair people of the subgroups are really the gatekeepers for participation in those work group settings, but anybody's welcome to attend the quarterly meetings. And there's a website for that too. It's DMHA's Recovery Support Work Group.
Awesome. And we can, when we post the recording, we can post those links as well for folks. Great. So kind of continuing on the theme of the council and the representation on the council, can you share just a bit about, you mentioned, Amy, that on the Recovery Council, there's current maybe underrepresentation for folks with lived experience of significant mental health issues. Do you have a rough breakdown of sort of, when you say lived experience, how many folks are identifying as mental health, substance use, both, and then family or natural supports?
For the Indiana Recovery Council, it's a little bit more gray. We just generally know that the conversation typically veers off into the substance use disorder realm more so than the mental health. So we know holistically, just looking at the members, that mostly we have people with addiction lived experience or substance use lived experience compared to mental health. Now with the Recovery Support Work Group, we actually have a survey that captures that and has people self-identify. We've not done that with the Indiana Recovery Council, although they do identify within their application. I just don't have the breakdown off the top of my head.
Great. Okay, sounds good. Let's see. And then one other question sort of related to the council, and then we can move on to some other groupings of questions. And that's in some of the slides that were presented, there is some language that's more clinical based. Has there been any discussion on the council about the clinical vocabulary in some of the survey tools? And Amy, you don't have to be the only one to answer too. If other folks would like to chime in, please do feel free to come off mute.
That's what I was waiting for.
So the cans and ANZA is really a discussion. It's not, a survey. So I don't know if they're talking about that. So that's not a clinical sort of thing. It's actually it's used by child welfare mostly. So that's not clinical in nature. I don't know if that answers their question.
Yeah, and it sounds like maybe it hasn't come up yet on the council, and I do wonder, just extemporizing here, that it may be if there were more folks, who've got experience in the mental health advocacy realm who are on the council, they may react to some of the terminology and some of those assessments. So yeah, something to flag or to think about. All right, let's see. We had a couple of questions around screening for traumatic brain injury or TBI, or if data are or if data about traumatic brain injury are identified or used. And thank you for answering in chat that the CANS and ANSA don't screen for TBI, traumatic brain injury, but there is some other information. Wondering if there have been any discussions or any uses of the data to specifically look at, the behavioral health related needs or the recovery outcomes for people who do screen positive for traumatic brain injury.
We haven't specifically looked at some of these items with the other data that we collect. So that's definitely something on our radar, but we are rather new to looking at the assessment data. So we haven't done that yet.
Cool. Thanks. Thank you, Wendy. And yeah, some of these, I feel like these Q&A processes come up with a lot of good ideas for the future. And I know when you have such rich data, there are sort of endless ways to use it. So a recommendation there to perhaps explore the needs of folks with traumatic brain injury. Okay, let's see. You know what, while we're on the topic of the CANS, can you share just a bit more about whether the CANS assessment is used in place of or goes side by side with any sort of plan authorizing services? So how does the sort of assessment data work with the service authorization data for the I think this question was specific to the CANS or ANSA, but maybe any of these data, how might they be used into in a service planning function?
So in our state, I'm not exactly sure if they're, so the CANS and ANSA data can inform what needs to be on the treatment plan. So they say actionable needs and buildable strengths should be on the treatment plan. In our state, it's also utilized for decision support for a Medicaid rehabilitation option. And so people, the consumers can get a package of services depending on how the whole assessment is, what the recommendation of the whole assessment is. So I don't know if that was where he was going or if that answered his question.
So it sounds like then these data are used for to inform service decisions as well as for the purposes that you've been describing
Yes.
here. Awesome. Thanks, Wendy. Okay. I want to ask about some issues around sort of representation and ensuring, that the folks who respond to the survey are racially, ethnically, linguistically diverse. So we had a question come in that asked if there are any languages besides English that the survey is offered in. And Amy, you were able to quickly answer that question. Thank you. And say, no, not currently, but that's something that y'all are going to consider in the future, which feels really important. Wondering if you can say a bit about how these data might be used to inform any efforts at the DMHA to promote equity, to work toward equity, in terms of race, ethnicity, culture.
This is Amy. So last year was the first year that survey was administered electronically. In years past, it's been a paper survey only. And to my knowledge, it's only been offered in English as well. But last year, we made it more comprehensive. We included SAMHSA's dimensions of recovery and made it available electronically. It was 6 months into the pandemic, so everybody was really online at that time. So this next year, we've contracted with a vendor to standardize the survey. And so that conversation about translating it into other languages is definitely on the table. So it hasn't come up yet. So I'm so happy that it came up so that we can bring that conversation to the vendor. But as far as how we've been using it internally, we, like the addiction team specifically, was meeting to do their strategic planning for the next, I think Becca knows, I think a 2-year or 5-year planning, strategic plan for the whole addiction team across the division. And they use that lived experience, and equity is being addressed across our division in every team. So the lived experience is definitely being utilized, quite honestly, much higher than my expectations. We've presented it to each of our advisory councils. We've presented it to our staff, and it's on the website. So we're getting it out there. It's being used, but we are still kind of early because that survey only went out last year. So any concrete changes or outcomes from that are yet to be seen.
Great. Thank you, Amy. It's cool to hear about the journey you folks are on, and really seems like you have a lot of power and opportunity with the data that you're collecting to do some awesome work in the equity space. So that's really exciting, and really exciting to hear that you'll be looking at translation as well. Let's see, I believe folks are more than welcome to add questions into chat. One additional question: do you look at monthly civil commitment data by county? Is that a data point that you're looking at?
This is Amy. Sorry, I feel like I'm doing a lot of talking, so I apologize. So I have not seen it. To my knowledge, none of the subgroups are looking at that. But what I will say is that our division director, Jay, who was on the call earlier, used to be the director for legal services. And so they're working on some it's competency restoration projects. So I don't know if that data is out there. Wendy, do you want to weigh in? Have you seen that data at all?
So we've not been looking at that data. No.
Okay. I haven't seen any. But I can't help but wonder if we can't access that through, okay. We'll look into it.
Okay. All right. I believe that we have gotten through the questions. which is good because we're just at the end of the hour. Just a couple of things to wrap up. One, I saw that Rebecca put the URL for the Recovery Supports Work Group into chat. So if you are a Hoosier and you're interested in perhaps learning more or seeing if you can get engaged, you could check out that link. And then for the Indiana Recovery Council, you could also Google Indiana Recovery Council to get that link, and we'll include those when we post the resources for this webinar. I want to really just thank certainly Amy for your incredible leadership of this initiative and the way that you were able to bring together this impressive panel of folks. Thanks to Jay for the support from the very top for this initiative. I think it's really remarkable to have that kind of support and buy-in from a director. And thank you to Becca, Sarah, Tina, Ari, and Wendy for sharing all of your wisdom and knowledge. And finally, just a note to say that we're really excited to partner with the National Association of State Mental Health Program Directors for this webinar. NCAPS is a center that is available as a resource to any human service agency, whether they are serving people with intellectual developmental disabilities, brain injury, mental health or substance use concerns, older adults, physical disabilities, any humans. We are here as a resource. So really excited to be able to sort of elevate and focus on the specific work that is happening in Indiana around mental health and substance use recovery. A recovery-oriented system is a person-centered system, and vice versa. So we use different words sometimes, but I believe that the values and the approaches are quite compatible. So thank you to David Miller for your leadership in this area. If we could just pull up one final slide, we'd love to hear what everyone thought of this webinar. We use your responses to improve our webinars month over month. So please just take a quick moment to respond to the questions. You'll want to scroll down. There are 6 questions in total. And if you could just take a quick moment to respond to them before you log off, that would be great. So thanks everyone, and have a wonderful evening or afternoon, depending on where you are in the country. Take care, and we'll see you next month.